All right, thank you all for joining us for our first Allina Health weekly provider update for COVID. My name is Dr. Sarah Preble. I'm a hospitalist at Abbott Northwestern and one of the COVID MD leads for the hospital. I'm joined by Dr. Rachel Lanasa, an infectious disease doctor at Abbott, along with Dr. Daniel Anderson, another infectious disease doctor at Abbott. Our hope is for these educational presentations to be done on a weekly basis, with the next week's one being a live webinar format where you will be able to type in questions that our infectious disease doctors can answer live. As always, with this COVID pandemic, things are changing at a rapid pace. So what we present today on March 20th may not be true even as soon as tomorrow. So what we are saying now is as up to date as we can be. Also remember that the AKN is updated daily and should be the source of truth for Allina specific policies regarding COVID. I'm going to hand this over to Dr. Lanasa to present her slides.
All right. Hello, everybody. Yes, my name is Rachel Lanasa, and I'm one of the ID docs here at Abbott, and I am going to talk a little bit about COVID. All right, and so we'll start with kind of talking about the current epidemiology. So in the United States, we are now above 10,000 cases with 150 deaths reported. As you can see, we have cases all across the United States, with most cases kind of occurring on both coasts. In Minnesota, as of last night, we have had 89 positive COVID tests. And as you can see, most of the tests, positive cases are located around the metro area. Within Allina, we have identified 17 positive COVID tests. And an update on testing that was made this past week. We are really kind of only focusing on testing patients who are both in the hospital admitted and healthcare workers. We are not at this point able to offer testing for outpatients because of testing supply. And within Allina, we made a change just yesterday in that we are sending all of our testing to LabCorp. And so I'm going to talk a little bit about our testing algorithm that we have here, which is, as most things, available on the AKN. And so basically, if your patients come in with an acute febrile respiratory illness, we would want you to initiate enhanced droplet and contact precautions with eye protection, keep the door closed. And if the patient is not sick enough to require hospitalization, unfortunately, we are not able to offer those patients tests. So what we would say is they should be discharged to home with self-isolation until they're symptom-free for 7 days, and keep a mask on them until they go home. However, if these patients are sick enough to be hospitalized, or if they're a healthcare worker, then we would move forward with consideration of testing. And so if the patients are being admitted, we would recommend initially starting with a chest x-ray and also an influenza PCR, because patients can certainly be co-infected with influenza and COVID. However, if they are influenza positive, we can treat that with Tamiflu. So that would be good information to know. And after that, if the patient, we would consider if the patient had other explanations for their respiratory illness, something kind of overt, like a potentially an aspiration pneumonia or something that seems to kind of clinically not correspond with COVID, we would treat as usual. And you don't necessarily have to test those patients if you have a clear alternative explanation for their respiratory illness. However, if you don't, we would go ahead and start testing on those patients. So now I'm going to talk about the clinical presentation of COVID. And so we're going to go through some signs and symptoms that have been aggregated within China and reported in the New England Journal of Medicine. So as we know, most patients who we're seeing hospitalized and symptomatic with COVID are older. The most common symptom that we are seeing is cough. The second most common symptom would be fevers. Interestingly, only 43% of patients who presented on admission had fevers in China, but then of those patients who were hospitalized, up to 90% of them did have fevers in the hospital. So fever is a very common symptom in patients who have COVID. However, there are some patients who have COVID who do not have fevers. This is all really confusing, I understand, because we're seeing a lot of respiratory illnesses this time of the year, and it's hard to determine what's COVID or not. So it can be difficult. One thing that is coming out recently is some reports of patients who have developed kind of sudden anosmia or hypojusia, so inability or impaired smelling or tasting. So that could be something that if you do see a patient and they do note that, that could kind of maybe make you think possibly COVID. However, this is kind of an early signal that we are seeing that might help us kind of differentiate between a patient who may have COVID or a patient who might just have a regular respiratory illness. So some labs that might be suggestive of COVID. So COVID can be very, very inflammatory. And so what we're finding is inflammatory markers might suggest patients have COVID. So up to 60% of patients in China who had COVID had an elevated C-reactive protein. Most of these patients had a normal procalcitonin, which you would expect with a viral illness. 41% of patients had an elevated LDH, and then around 20% of patients had elevated transaminases. Another hallmark of COVID is actually lymphopenia. So up to 83% of patients had a low lymphocyte count. So that is another set of labs that might suggest that a patient may have COVID. There's been questions about kind of respiratory viral panels and how useful these might be, because, if you get a respiratory viral panel on a patient and they're positive for a non-COVID respiratory illness, could that necessarily rule out COVID? And just full disclosure, at this point, we do have respiratory viral panels. They're only available for use for ICU doctors and ID, but I did want to bring this up because initially it was reported that the co-infection rate was actually pretty low, reported around 2 to 5%. However, there is some data that's coming out of California that up to 22% of patients who had COVID actually had another co-infection. Full disclosure, it seems to be most of these viruses were non-influenza viruses. However, there is possibly a higher rate of co-infection with other respiratory illnesses with COVID than we thought before. So I wouldn't necessarily, if somebody had a compelling clinical presentation that seemed consistent with COVID, if they had a positive respiratory viral panel for one of these other viruses, I wouldn't necessarily use that to say they absolutely don't have COVID and they don't need to be tested. So I think this is something to consider. I do think flu testing, however, is still valuable because if a patient has influenza, whether or not they have COVID at the same time, we have a treatment for influenza, and it would be nice to know that the patient has it so we can start them on Tamiflu. So now we'll move on to imaging. So interestingly enough, there does seem to be kind of a typical progression of CT findings in patients who require hospitalization with COVID, so patients who are hypoxic and who are relatively ill. And so I think this is interesting and useful because, as we know, testing is very limited and has been taking a couple of days. So one kind of adjunct that we can use or a surrogate for PCR testing might be CT. And so I thank you to Dr. Berglund, one of the chief residents here, who helped me put together these slides with imaging. So findings that are consistent with COVID-19, so primarily ground glass opacities, bilateral. We're finding most of them are happening in the lower lobe, and interestingly, most of them are actually very peripheral. We are seeing a fair amount of consolidation in these patients as well. Findings that are not necessarily consistent with COVID would be pleural effusions, lymphadenopathy, nodules, or cavitation. So we'll just kind of go through a couple of CTs. So on your left, you'll see kind of the progression of so this is an initial kind of ground glass opacity, and then this is kind of the patient CT findings kind of over time. And so you can kind of see that ground glass opacity that kind of is transforming into a consolidation. And then on your right side, you're going to kind of see what classically looks like peripheral multifocal ground glass opacity. So kind of on the periphery, you kind of see these kind of hazy ground glass opacities. And so these are kind of typical findings that we are seeing in patients who have COVID requiring hospitalization. So now we'll kind of move on to the illness features, and this is still dynamic. We're still doing a lot of research and we're still learning a lot about COVID. But at this point, kind of the thought is that there's kind of multiple stages of illness. So you kind of have your initial replicative stage where patients will have kind of typical URI symptoms, and you kind of develop an innate immune response. You might have fevers. There are a subset of patients, as we know, who within this stage are actually probably asymptomatic. And then the problem is the second stage that we're seeing. So when the adaptive immunity stage kicks in, either patients will clear the infection, which is most patients, or what we're seeing is kind of this excessive pathologic immune response. What we're seeing is kind of this cytokine storm where patients are developing kind of almost like a secondary HLH with pulmonary involvement leading to ARDS, up to 20% of patients, and multi-organ failure. Interestingly enough, elevated ferritin and IL-6, IL-6 is a cytokine, are predictors of mortality, and ferritin is an inflammatory marker. And we see high ferritin levels in primary HLH. And really, respiratory failure and ARDS is the primary pathology and the leading cause of mortality that we're seeing in these patients who basically have this exaggerated immune response that we're seeing. Another important cause of illness that is kind of coming out is viral myocarditis. That is something to keep an eye out for. So treatment for these patients, so supportive care, supportive care, supportive care. In our patients who come into the ED and look well, or patients who even are admitted initially and kind of turn the corner, it is okay for these patients to go home and just give them the guidance that they would need to self-quarantine for 7 days after the illness onset, or 72 hours after the resolution of the fever without antipyretics, whichever is longer. I would like to tell these patients, however, that if they were to get worse at all, so if they were to move out of that kind of initial stage into that second stage, that they would need to come back if they were developing worsening shortness of breath, that they should come back in and seek care. But, I do want to let people know that these patients don't necessarily need to stay in the hospital for the entire duration of their illness, and they don't even necessarily need to stay in the hospital until their COVID test comes back, as long as they are well enough to go home. One myth that I kind of wanted to bust up front, there was kind of some rumors online as to whether or not patients who have COVID or suspected COVID could get NSAIDs. And at this point, the WHO came out with a statement saying that there is not sufficient evidence to say that these patients shouldn't get NSAIDs. And so I would kind of use NSAID therapy as we would for any other kind of NSAID treatment that we would use for these patients. So probably not give it to elderly people or people who have kidney disease, but that at this point it seems that NSAIDs are probably okay for patients who have COVID to break their fever. And then for critically ill patients, so the patients who are kind of having this maladaptive immune response. So some early tenets of treatment that we're seeing is kind of fluid-sparing resuscitation. There has been some concern that patients who have this huge inflammatory response in their lungs, that giving them fluid might kind of exacerbate that. So trying to, be mindful of how much fluid you're giving these patients. Definitely early intubation is something that we kind of are seeing other facilities and here kind of move towards. One, because a lot of these patients, if they are requiring significant respiratory support up front, lots of times they're going to need to be intubated because the disease typically will get worse before it gets better. And then also, if a patient is, let's say, needing BiPAP, we are considering that an aerosol generating procedure. And moving them to intubation early would also help prevent that kind of aerosolization and that threat to the workers and other people who might be in the room. Typical ARDS treatment is definitely a tenet that we need to, continue with these patients. So, PEEP, proning, doing all kind of best practices for ARDS is important. And then I really think kind of potentially, especially for elderly patients, considering early palliative involvement is something that might be important too. Really being able to define goals of care, I think, is something that we really need to consider moving forward. And so now I'm going to kind of talk about possible medical therapies for these patients. And full disclosure, no therapy has been proven to treat COVID-19 in humans. This is all very investigational. There are multiple clinical trials that are ongoing, and there is some anecdotal and kind of retrospective data that has come out of China and Italy. But we really don't have many randomized control trials. Secondarily, availability is a concern across the nation, across the world at this point with a lot of these therapies. What we do know, however, is that probably early therapy is better than later therapy in the course of illness. So being able to kind of intervene early is just like in the flu. It seems to be kind of the same concept for COVID. So the initial therapy that I'm going to talk about is chloroquine and hydroxychloroquine. So chloroquine is an old anti-malarial medicine that we have. Hydroxychloroquine works by the same mechanism of action, but the nice thing about it is it has a much better tolerability profile. And so what these medications do is basically create kind of a alkaline or basic environment within the cells, which interferes with viral trafficking. And also interfere with blocking or interfere with binding of COVID to human cells via the cellular receptor ACE2. In vitro, the data is pretty good, and it shows that it does inhibit COVID replication. However, we don't have great human data at this point. There is some observational data that has come out of China, and it is hydroxychloroquine and chloroquine treatment is in the Chinese and South Korea guidelines. Of note, there is a University of Minnesota post-exposure trial that is going on, and it is basically giving hydroxychloroquine or placebo to either healthcare workers or household contacts who have been exposed to a known COVID case within 3 days. So if you're interested, that's the email that they have there. The second therapy is remdesivir. So this is an antiviral that was initially looked at for Ebola therapy, but it has shown activity against SARS and MERS in the past. Clinical trials are ongoing at this point across the nation. At Allina, at this point, how remdesivir would be accessed is via compassionate use request through Gilead, which is typically, it seems like they are turning around the request within 72 hours. There are some inclusion and exclusion criteria that I wanted to quick mention. So inclusion criteria would be patients who are hospitalized, confirmed COVID by PCR, and on the vent. Exclusion criteria is pretty strict. Patient cannot have evidence of multi-organ failure, cannot be on pressors, cannot have markedly abnormal ALT or significant renal dysfunction. And patients cannot be on the remdesivir at the same time as they are on other potential COVID agents. However, patients can be on the other experimental therapies up until they get the remdesivir. They just can't be on the remdesivir at the same time. Another possible therapy that has been looked at is lopinavir ritonavir, which is a HIV medication that we use. It's a protease inhibitor antiviral. It was recommended in the Chinese treatment guidelines. However, just this past week, there was a randomized control open label trial, which actually showed no difference between lopinavir ritonavir and placebo as far as no changes in mortality, time to clinical improvement, or viral clearance. So unfortunately, it looks like this probably isn't a great treatment at this point. And then there's another therapy called tocilizumab, which is basically it's a monoclonal antibody used against IL-6, which we have used in the past for rheumatoid arthritis. And the thought is we know that there are high IL-6 levels in these patients who are in that kind of second stage of their illness where they're having this huge cytokine response. And so the thought is if we could bind the cytokine, maybe these patients would do better. It is recommended in the Italian and Chinese treatment guidelines, and there are clinical trials ongoing. Availability is definitely a concern, as is cost. So this past week, we put together a set of guidelines for these treatments at Allina, and I'll just kind of quick go through the treatment algorithm. Just so you know, this is once again on the AKN under provider resources, and the medications at this point are restricted to ID and the intensivists and pulmonologists. However, if you have any questions, just feel free to call us in ID. We're happy to help walk you through these. But basically what we're saying is if patients are receiving ICU level care, we are recommending considering starting hydroxychloroquine while initiating compassionate use application for remdesivir, which I'll talk about in a second. If COVID-19 is confirmed, we are also thinking about patients who not necessarily are not requiring ICU level care, but are older or who have comorbid conditions, and patients who are on kind of step-down therapy, these patients who might not be ill enough to be in the ICU or have significant oxygen requirements, but who do have comorbid conditions, who could potentially move on to that second stage of illness, which once again, we are trying to avoid. Consider hydroxychloroquine if they are positive. And I'm going to, here are the guidelines. So preferred upfront, initiating possible remdesivir, initiating the process through Gilead to obtain remdesivir, and considering hydroxychloroquine use. Alternatives that are restricted to ID, which once again don't have a lot of evidence for, but we have in our back pocket if we absolutely need to think about using it, are lopinavir, ritonavir, and tocilizumab. And so this is basically the steps that you would need to go through to obtain compassionate use through Gilead. It's basically going through their website and having to go through our IRB and going through the FDA. So once again, if you have any questions, just give us a call on ID. We can help you walk through it. I know it's a little complicated, but if we can start this early in patients who meet criteria, earlier is better. So therapies that are not currently recommended at Allina are corticosteroids. So we're not recommending them for ARDS caused by a viral pneumonia caused by COVID. However, it is okay to use for other indications if necessary. So if somebody has COVID and has a COP exacerbation, I think that's just fine. ACE inhibitors and ARBs, so we are recommending against initiation for COVID specifically. There's some kind of thoughts mechanistically about, increasing ACE2 inhibitors, whether or not that could be dangerous or useful. There are some studies that are in process, but we wouldn't recommend starting them specifically for COVID, but we wouldn't necessarily recommend stopping them either. The American Heart Association and American College of Cardiologists just came out with a statement a couple of days ago that said it's okay to continue ACE inhibitor and ARB treatment on patients who come in and have COVID, unless, of course, obviously they have hypotension or some other reason why you would stop it, but otherwise just to continue patients who need it on their therapy. We wouldn't recommend at this point use of other antivirals, so darunavir, Cobi, which is an HIV medicine, ribavirin, baloxavir, oseltamivir, or interferon alpha at this point. So I wanted to talk about prognosis. So it seems that the mortality worldwide per the most recent kind of WHO update is around 3.7%. In the United States, we are currently at 1.4% mortality. Predictors of mortality at this point seem to be advanced age, presence of underlying diseases, so patients who have diabetes, COPD, cardiovascular disease, hypertension, the presence of a secondary infection, and then interestingly kind of elevated inflammatory markers kind of seem to confer a poorer prognosis for these patients. I think once again, because if these are elevated, then we know that that patient is almost certainly in that second stage with the cytokine storm. And so here's kind of here's a study that looked at elevations in CRP, myoglobin, troponin, IL-6, and you can see that the patients who passed away had higher levels than patients who didn't. And then SOFA score also, when patients are admitted, is associated with worsening outcomes. As far as how patients are passing away, it looks like mostly it's going to be respiratory failure or ARDS. However, there is a fair amount of patients that are dying from myocardial damage. So that is, once again, be aware of myocarditis in these patients. So we're going to talk about PPE for a second, because I know this is a question that a lot of us have right now. And so what we're recommending at Allina at this point is basically for PUIs and confirmed COVID cases who are not getting aerosol generating procedures. So what we're considering aerosol generating procedures at this point is right here. So sputum induction, open suctioning, bronchoscopy, intubation, extubation, patients getting bagged, neb treatments, CPR, BiPAP, and CPAP. So patients who are not needing that, we are recommending enhanced droplet and contact with eye protection. For patients who are getting any of these, and or patients in the ICU, because patients in the ICU may need any of these at any given moment, then we are recommending enhanced airborne and contact with eye protection for these patients. So I wanted to talk about kind of the science that we have behind this at this point. And so I know everybody's been kind of talking about this New England Journal study that just came out a couple of days ago, where basically what they did is they had aerosolized the virus via nebulizer and did find that there was traces in the air that were aerosolized up to 3 hours after being nebulized. However, I wanted to stress that this is A, under perfect lab conditions, and B, aerosolized. It was aerosolized, and we know that if this is aerosolized and patients are having an aerosol generating procedure, that it is airborne, which is why we're recommending the respirators. In a Singapore study that was done, they actually found that there was no aerosolized coronavirus particles in the patient rooms. So so basically, we know that it can exist as an aerosol given under these lab conditions, under limited conditions, but we know that if something is that we are protecting ourselves, and that if we are completing an aerosol generating procedure on these patients, we are wearing airborne wearing airborne PPE. And so the question as to whether or not it's aerosolized or transmitted via airborne, and just kind of regular patients who are not getting these very invasive aerosolizing procedures, I think that we would be seeing a whole lot of a different transmission pattern if this was how it was transmitted, because we've looked at kind of the rates of transmission amongst household members versus other close contacts, and we're finding that patients who are just people who have had just casual contact with patients who have COVID, the transmission rate is very low, whereas we would expect this to be much higher if this was transmitted primarily via airborne in patients who are not getting aerosolized procedures done. And then I just kind of wanted to go through a case study. So there was a patient in the United States who came in, was intubated for 4 days, and then extubated. And after being extubated, he tested positive for COVID-19. So basically, throughout this period of time, most of the healthcare workers who had been working with him were not wearing N95s. And most of them were actually only wearing surgical masks. So this is a patient who was intubated, extubated, which are by definition aerosol generating procedures, and actually none of the patients or none of the healthcare workers who had contact with the patient, despite most of them wearing just regular masks, developed signs or symptoms of COVID, and all of them swabbed positive across a span of swab negative across the span of 14 days for COVID. So I think that is kind of encouraging that this is not how it is being transmitted. So none of the healthcare workers developed symptoms, and all PCR tests were negative. And in this situation we described, 85% of the healthcare workers were exposed during aerosol generating procedures while wearing just a regular surgical mask, and nobody acquired the infection. So a couple take-home points today. Testing is still a challenge. We're still limited with tests. We are moving to LabCorp to try and help our turnaround here. Symptoms to look for in evaluating COVID patients. So cough, most common symptom, fever, URI symptoms, and then, consider maybe, if you're seeing patients who come in and complaining of anosmia or hypergeusia, consider COVID. Labs that we're seeing, lymphopenia, elevated inflammatory markers, and then once again, beware co-infections if you are moving forward with a respiratory viral panel. Imaging, so CT can be a useful modality to kind of help us as a surrogate while we're waiting for PCR testing. What we're really looking for is kind of these classic, it seems to be peripheral ground glass opacities. The pathology that we're seeing most in these patients is the ARDS part, but beware viral myocarditis too. At the end of the day, supportive care is key. And restricted therapies that we have currently at Allina for our critically ill patients are hydroxychloroquine, Kaletra, and tocilizumab. We're most probably going to use those less. And then remdesivir is available as a compassionate use through Gilead, and we'll need to kind of go through some paperwork. Earlier is better. Note the inclusion and exclusion criteria. And droplet plus precautions are okay for non-aerosolizing procedures, and that is what we were doing. I also wanted to note that everybody else in the Twin Cities, all the other hospitals, are doing the same exact thing that we are, droplet plus, with the exception of patients who are having aerosol generating procedures. And then at the end of the day, this is a rapidly evolving situation. Things are changing day to day. New research is coming out. So, everybody keep their ear to the ground. Read the daily updates. Things are really rapidly changing. And we will stay on top of this and keep everybody updated as we are able. Here are my references. Some really good, data is coming out there. So feel free to go ahead and do some reading if you're interested.
Thank you so much, Dr. Lanasa, for that really great presentation based on the evidence that we do have available to us at this time. Dr. Lanasa touched on the fact that all of the decisions made at Allina are made through the system incident command centers, as well as each of the hospitals' individual incident command centers. And when we make big changes like the testing change that happened earlier this week or the PPE changes, those are made in partnership with health partners, mHealth Fairview, in conjunction with MHA and MDH. So any of those big changes, it's not just one system doing a one-off. It's a consortium effort that we have all been doing as a group and working very closely together. So thank you for watching this presentation. And again, this will be weekly, with the next one being a live webinar, so you can type in questions and our infectious disease experts will be able to answer them for you. Thank you so much.